Excellent. So we are ready to get started. Excited for this discussion of kind of state health plan strategy looking forward. I'm Brad Staats. I'll be your moderator. I am Ellison Distinguished Professor of Operations and Senior Associate Dean of Strategy and Academics here at UNC Chapel Hill's Kenan-Flagler Business School. I'm also the faculty director for the Center for the Business of Health. I'm joined by two great experts and fantastic individuals for today's discussion. Let me introduce both of them and then we'll get right to the questions. First, we're joined by Tom Friedman. Tom is the executive administrator at the North Carolina State Health Plan. He spent almost 20 years in healthcare with a particular focus on state government, payer strategy, and health systems. Before his second turn in working with the state health plan, he spent about 6 years at Duke Health. Prior to that was at the North Carolina State Health Plan, also the North Carolina Health Exchange Board, and multiple consulting and health analytics firms. So a great perspective to help us dig into the topics today. Tom, appreciate you being with us.
Thanks for having me.
And then second, we also are joined by Dr. Brian Miller. Dr. Miller is a practicing hospitalist and associate professor of medicine and business at Johns Hopkins. He also serves on the North Carolina State Health Plan Board of Trustees. In addition, he brings an extraordinary breadth of experience, really working across the healthcare system that we'll be able to draw on today. He's worked as a medical officer at the Food and Drug Administration, special advisor at the Federal Trade Commission, and a fellow at the CMS Innovation Center. In addition, he's currently on a number of national boards and commissions. In particular, I'll call out his service on MedPAC, as well as the UNC and NC State Biomedical Engineering Industry Advisory Board. So Brian, appreciate you being with us today.
Thank you for having me. And I have to note that my views are not necessarily those of MedPAC or the other commissioners.
Excellent. So yes, appreciate that perspective. So really the goal is kind of to start sort of high level, and then we'll dig into different pieces. I should certainly say to the many likely state employees and members of the state health plan who are here, we're not trying to get into kind of all of the benefits changes and such. I'm sure your different HR departments are running some great webinars around that. And so I'd strongly encourage you to attend those and understand for open enrollment purposes the opportunities here. We want to kind of look at the changing nature of healthcare, excuse me, and the opportunities therein. So, maybe Tom, I can start with you with this first question. Could you give us kind of a big picture view of where the state health plan is today, what's working well, and what do you see as the biggest challenges on the horizon?
Yeah, thank you. So I think what is working well is I think we've got ourselves back on good financial footing. I think when the treasurer and I came in January 1st, we were facing a over $500 million deficit for 26 and over $1 billion deficit for 2027. We had issues with how we were funding our state employees. We also had some real cultural challenges that I think were difficult. A big part of healthcare is health, and we had not invested anything in population health in 8 years, literally $0 and 0 cents. So we got folks out of the practice of incentivizing healthy behaviors. We also got folks out of the behavior of there is cost differentiation depending on where you go for what and what things. So creating a culture of status quo really leads to some challenges. And so I think by shaking things up, I think we've moved in a direction of healthcare is changing, costs are changing, but we need to invest in you, the member, and we need to get that money, not just from you and your premiums and your costs, but from other providers. And we need to better empower you to make decisions to lower some of your healthcare costs. So I think what is working well is I think we've articulated and kind of communicated the dynamic needs to change. I think what is maybe not, I wouldn't say going well, but it's something that's a challenge is we had a new third-party administrator come in January 1st, 2025 as well. So you think about all the cost pressure changes, all the challenges there, and you also have a new third-party administrator. Blue Cross of North Carolina is an institution here. If you've lived in the state of North Carolina for longer than 30 seconds, I'm sure you've been on Blue Cross of North Carolina in some capacity at some point in time in your life, and you're very familiar with it. one of the mistakes the previous administration made was they said nothing is going to change when we switched over to Aetna. Well, if nothing was going to change, then there's no reason to make a change. Things are always different when you have a new entity and a new stakeholder in place. And some of those changes have candidly been pretty rocky. Some of them I will say have been own goals by Aetna. Some of them are policy decisions we made at the state health plan. And some of it is just the normal transition of things. So while we strive for operational perfection, I think we are working back towards how do we help set Aetna up for success with our membership, how they communicate with the provider community. We were kind of joking beforehand about what's going on with Duke at Aetna and how that's rolled out. I think that is a public spat that is very different than how Blue Cross has traditionally engaged with folks as well. So I think what's going well is also what's been the challenge is there's a lot of transition. We have a new board member in Brian who's here to shake things up and kind of do things a little bit differently. So a lot of change creates opportunity, and it also creates us to give ourselves an honest assessment of what's not going well and how do we continue to make that better.
That's a great kickoff. Thanks. And I should open up to the audience. Down at the bottom, there's a place for you to kind of input questions, and so I'll be tracking those as we go along through the conversation. Please feel free to engage in that way. So as you're highlighting the status quo kind of bias and overcoming that means that we're going to have some change, and some of that rocky, some of it hopefully on the smoother side. I guess, Brian, any kind of initial framing from your perspective you want to add on to what Tom shared?
Yeah, so I joined the board in January, and you walk in the door and there's a $500 million deficit. And then the subsequent year thereafter, there was a projected $900 million deficit. So I think the first thing is it's like stop the bleeding on the patient, right? Because a $500 million deficit on a $4.5 billion plan, like we all had to collectively, all of us, the state health plan board, the employees, the plan members, the state government, the hospitals, had to stop the bleeding. And so I think that the approach that was taken at the end of the day was a practical one, which is hospitals need to come to the table, and very grateful that Duke, as you saw in recent news, has chosen to come to the table, as have all the other health systems, UNC, Advocate, etc. So they have to come to the table. Thankful for the state legislature for giving $100 million to the state health plan to also help plug that hole. So the state government and the hospitals, and then other things like updating the benefit design and updating premiums for the first time in a decade. It's a combination of everyone coming together to make sure that that $500 million hole is plugged and the state health plan remains solvent.
Sure. So, 500 million going to 900, certainly big numbers, important numbers to address. And so let's talk a little bit about that. The state health plan released kind of the news when they shared the premium increases, that the program would be kind of financially stable through 2028. And so would love a little more around what does that mean in practice? Are we talking about just breaking even? Is that building reserves for future needs, or what does that look like? And maybe Tom, give you a chance to start with that one.
Yeah. So one thing you mentioned was this is round 2 here for me. So when I left the first time, we had about $1 billion in reserves. When I came back, we had functionally none. So we are aiming towards building back reserves so that, one, for 2 reasons. One, so we can invest in the health of our members, right? That's not free. If we are spending $1 on health and health improvement, that first dollar's got to come somewhere. And candidly, it's the right thing to do because folks generally stay on the state health plan a lot longer than they do other plans. So part of building reserves is that's how you invest to save money, right? So when we think about what it means financially stable is if we get on a pattern of regular premium increases, regular provider negotiations, continuing to retool our pharmacy benefit manager program, we have moved in a direction where we are making changes that we will not run out of money. And hopefully we are building towards building additional reserves and that reserve capacity so we can continue to do some more novel things to invest in health.
And, with kind of that 2028 as a target, does that mean, that members should be thinking that there'll be premium increases in 2028 once the stability is achieved? Or I appreciate always hard to forecast.
Yeah, no. So I would say a general rule of thumb and what we're shooting for. If we hit that in 2028, if we hit that in 2027, I would say, generally speaking, the treasurer's stated goal is to increase premiums every year by the amount of salary increases. So
Okay.
trying to tether it a little bit more predictably to the amount of money coming out of the wallet is proportionally the same every year. So I
And
would anticipate premium increases every year going forward.
Got it.
But tying that to how much salaries are targeted to increase by the General Assembly as well to kind of make sure we're keeping up.
And another thing that we did, which, it's stealing from my Medicare hat, is actually, so in Medicare, right, you have Part A, which is hospital benefits. There's no premium. You have Part B, which is physician benefits. Most people buy Medigap, and then there's Part D for drugs. Part B, which is again funded by the feds and also the beneficiaries through premiums, has an income adjusted premium, meaning if you're in the Medicare program and you have less money or no money, you pay less of a premium than someone who has more money, right? So if you make $300,000 a year as a Medicare retiree, your premium is higher than someone who has, say, $40,000 a year in income as a Medicare retiree. The state health plan actually didn't have that. So if you were making $35,000 a year working as a state health plan employee, your premium was the same as if, I could use physicians as an example because I am a physician, so push myself under the bus. If you're making $250,000 a year as a hospitalist, right, you paid the same dollar premium. And so one of the principles that we're going to try and adhere to is, one, have salary bands for premiums. So that way you don't punish the poor people. And the joke is that there are two primary rules in health policy. One is don't break the old people and don't be a jerk to the poor. And so this is sort of fulfilling that second rule of, if you make less money, your premium should be lower. And part of that comes into having a target percentage of your share of salary as the premium being similar across the
Got
pay
it.
bands. And therefore, those who make less money will have to pay less in premium compared to those who make more.
Got
Makes
it.
it more equitable. And again, makes it so that those who aren't earning as much money can still afford the state health plan benefits.
Right. And consistent with what we see elsewhere, as you're highlighting. Let's turn a little bit to kind of cost control strategies. And maybe, Brian, I'll start with you with this one. That, besides premium increases, could you talk a little bit about kind of specific cost saving measures that State Health Plan is implementing? And, both kind of that as well as what other measures might be considered going forward?
So, and big credit to Tom and the staff for executing on this. So when I joined the board, one of my questions again about thinking about costs was, what is the network strategy for the state health plan? And I think the answer is that the state health plan, like many large employers, didn't really have a clear defined network strategy. And that wasn't from the fault of the state health plan, it's just historically hasn't had the physical pressure to do so. And so if you look at like the exchange market or other markets, there is a network and there is a network strategy. And so the state health plan, I think, is implementing a network strategy for the first time with a PPO or a preferred provider organization strategy. And I would argue that, what we're doing is not even a full PPO, it's what I would call PPO light. Because previously the strategy in the state was any willing provider. So there are going to be a preferred network of primary care physicians, strong emphasis on independent primary care, which has a robust presence in the state of North Carolina. And then for specialty care, there will be functionally the health systems are going to compete for bundles of care, whether it's, say, orthopedic surgery, eventually OBGYN services. And then the idea is that members will have reduced or no cost sharing for the preferred providers, right? So not always zero, but less cost sharing, in some cases zero, if you go to those preferred providers. And say the preferred hip surgeon or hip surgeons, those are folks who the state health plan is going to be saying, hey, we have X thousand members who we anticipate needing hip replacements. We'd love to contract with you as one of, 3 preferred groups. Here's the pricing structure. We will drive volume to you, and you will take that volume and also drive quality through the quality volume relationship. And then for the member, despite, again, concerns about the fiscal picture of the plan, which we're working to correct, the member gets a clear picture of, hey, if you go to these doctors, your cost is near zero or much lower. And so that was part of the challenge will be to make that clearer to the members. And I think our comms team is doing a great job. And I know Tom can talk a little bit probably about some of the details of how we're going to operationalize this to make it simple and easy for the members. But that's a huge way to reduce cost. And it's a big shift in terms of plan strategy, and a positive shift, I think.
Sure. So Tom, maybe we can start with you to pick up where Brian left off there.
Yeah. So I'm going to give an example how it's going to work, and then how we're going to stop this sort of thing from happening again. So there is, for a diagnostic colonoscopy in some northern counties, it's something everyone over a certain age should be doing it. It is so much more expensive to do it in a facility that I could pick up every member in Granville, Person, and Vance County in a limousine, drive them into Raleigh to get the colonoscopy, drive them in the limo to the Umstead, leave them at the Umstead for 3 days to recover, relax, and recoup, pick them back up in the limousine and drive them all home. And I would still save thousands of dollars than having them participate kind of close to exactly where that's the difference in cost variance here. So yep. While I would love to be a limo driver, and it would probably be a lot lower stress in the job I have, I'm not sure I can do it. I'm not a very good driver, if I'm being perfectly honest. So what we're going to do is we're going to make it free, or as free as we can, for members to go to that lower cost, higher quality place. And we're going to try to make it as simple as we possibly can. So one, if a member finds out they need a procedure, the first thing they should do is call Lantern. We'll have ID cards going out to every member across the state of North Carolina, so that they know when they have a surgical procedure or an elective procedure done. Call that is the path to free. I'm going to go back to my analogy one more time. Because access is equal in all parts of the state of North Carolina, we are paying for travel. We are paying for flights if necessary. We're paying for hotels if necessary, again, because the cost out there is so high. So first step, you need something up, call to see where you can get it for free. 2, for further reducing abrasion, because not everyone's going to call, right? Like if we get 20% of people to call, I'd be astonished. 2 is how do we let the provider know? Sorry, the independent preferred primary care network Brian did. We are working with them and ensuring savings with them by referring to those practices. So there's a shared savings opportunity for providers for engagement. So people, generally speaking, don't trust that now. They trust me a little bit more, but they all, generally speaking, trust their primary care provider. So if you get a referral from your primary care doctor, we've now incentivized by ensuring with your provider, the referral they're going to make is a better chance of a high quality, low cost referral for you, the member. 3, not everything, you don't go from primary care to surgery all that often. There's a lot of care between the way. So we're building out in our specialty network. How do we make this specialty copay? So let's say your doctor says you need to go to a cardiologist. 1, your primary care provider is going to refer you to this higher quality, lower cost setting of care. We're going to make the copay cheaper for you to go there. So if maybe you don't believe your provider, your copay is going to be less. And people, generally speaking, go with their wallets. And then, so you're already there. So if the time of surgery comes, you're already in the practice and already in the location where the lower cost of free surgery is. So you don't have to bounce around. We're trying to make the experience as simple and painless for members as we can. And we are going to hold the risk with that on the providers, right? We know we're going to save money based on the rates we've got negotiated, but we have to advocate for you in every way we can to get you to those locations, because that's where we get those dollars to invest in getting folks healthier, right? This is I don't get to go on vacation with the savings. I get to invest that money in kind of better population health and better health for folks. So I think the key is communicate and make cheap. and make obvious, right? And I think those are the mechanisms we're going to kind of use to get there, to kind of drive to some of those savings. And this is candidly just where we're starting, right? I think it's how you build some momentum, because if someone offered me something free, I'd be like, I don't know. I'm not entirely sure how good I think that is, but we vetted these providers, we work with other providers. So we want to get preferred and free as the places you should go. And I know there's some communication work to do there, because one, if your insurance company says they prefer you do something, I get that suspicious. If something's free, I get that suspicious. Because usually expensive means good. That's not true in healthcare. Expensive means expensive. And good is part of your experience. How are you treated when you get there? How are the outcomes? How much did you pay for it? So we're trying to build in a culture of understanding that free and preferred mean good, and that's going to take some time.
So let me go ahead,
I was
Brad.
to say the other thing with a preferred network, and this is not a stage one, but this is a stage 2 or stage 3 sort of thing, where is, the state health plan has a lot of purchasing power in the 2 metro areas in the state, right? Raleigh, I think it's and Tom can correct me, it's $1 billion in purchasing power, and I think in Charlotte it's around 800 or 900 million. And so in addition to thinking about cost, quality, and experience, right? The access component, right, is one of the things I think that we will be thinking about in the long term. Because if your job, for example, starts at 8 in the morning and the doctor's office is open 8 to 5, right? Can we get options for eventually Saturday or Sunday hours for some services? Or can we go to, say, an OB-GYN and say, hey, we actually want our members have jobs that start at 8. Can you potentially have early or late clinic hours? And those are sort of later titrations, but thinking about sort of the member experience at the risk of sounding using corporate corny language, matters a lot, because it matters for the member that they can get the care, right? If you have the care, if you can afford your premium and you can afford the care, but you can't get access to it in a meaningful fashion, then we still have not succeeded. And so I think that's the other part that we still have to work on more broadly.
Sure. So I want to kind of ask a couple of follow-up questions on this, and then I want to turn to some participant questions too. So first, Tom, you mentioned Lantern, and this is a new partnership that, as I understand it, is what's going to enable kind of these centers of excellence kind of model that you're describing here. And so maybe could you just describe kind of mechanically, from a state health plan perspective, what do you see? And I appreciate it's in some way summarizing kind of that longer discussion we just had of what the Lantern partnership is really bringing to the table.
So they're bringing a few things to the table. One, I think while bundles sounds simple to say, there is some technology behind it. So there is a technology solution that drives it. And while the state health plan has a lot of scale, they bring additional scale in terms of they have clients in North Carolina, they have a network in North Carolina. They also have a pretty rigorous quality process. So quality is the front door to things. And so while Brian is an excellent doctor, I am not one. We do not have robust medical staff here. So we wanted to bring in a clinical team to evaluate providers to make sure we're not getting, and not to criticize new surgeons and new physicians, but the more you do something in surgery, likely the better. It's pretty well tied to quality. So having someone come in and validate the quality of providers was really important to us. And the last part of it, I think, of bringing them in was they had a very strong ASC network in North Carolina, ambulatory surgery centers across it. They agreed to partner with us to do a procurement statewide with the health systems to get a broader network of providers. That is something I candidly do not have the staff and bandwidth to execute on. And they have done that for the 6 Medicaid regions of the state. So we were in the final stages of negotiations on what those contracts need to look like. So they brought a lot of technology, expertise, quality, and just passion for the work here. So we could focus on all the other things. They're laser focused on a very narrow set of things.
Yeah, building off of that very briefly, there is a very strong quality volume relationship for almost every surgical and procedural part of medicine. And in fact, some board certifications, say interventional cardiology, requires you to do a certain number of cardiac caths per year. And so I think having a vendor who helps us think through that sort of quality volume relationship and how to operationalize it will be very helpful, because at the end of the day, the sort of the joke in medicine is, yeah, a procedure might have a very low complication or mortality rate, right? Maybe even 0.1%. But if you are that 0.1%, you have experienced
Sure.
100% of that complication. And so finding ways to make sure that in addition to reducing costs, we're improving the quality in a real way, I think matters a lot. Because as someone who has experienced complications and friends who have experienced complications, I mean, we all know that story of something that did not work out well. And so
Right.
making sure that we address that in a proactive fashion rather than a responsive, after the fact fashion, I think is helpful.
No, and I think Tommy, you said something earlier about expensive care is just that expensive. It sometimes can be high quality because there's a reason for it. It often isn't, and it's just this variability that we're talking about of the same procedure, coming back at very different costs. And so thinking about how to consolidate that volume, how to get the quality benefits that Brian was just talking about there is important. I guess I'm curious. I mean, clearly one of the takeaways for all the participants is to be curious, be inquisitive, to be asking questions for your own kind of care, but also kind of you highlighted the kind of independent pathway of someone who's not affiliated with a broader system. How are you thinking about the communication with members, the getting those phone calls to be made when someone gets themselves? We have several very powerful systems within this state that kind of flow through from primary care all the way to specialty care to procedures. And in some ways, you may be looking to break that down as you get people channeled to different sources to be free or to be lower costs. How are you thinking about that communication challenge?
I think it's a really good question. And it's something the treasurer said to me, and I'm going to let Brian validate this point. We're focused on economies of scale, not economies of scope. So not every health system is equally good at everything or has made the same investment in every service type. One of the unique advantages large commercial insurers have had is that we pay the most money of the payers for care. So when economic times get tight, and volume goes down and other businesses are spending less on healthcare, the state doesn't go away, right? Like the state needs to serve, teachers need to serve, universities need a university. In a lot of respects, our volume is the best volume. We pay more than Medicare, we pay significantly more than Medicaid, and we are the most predictable revenue. So that is sort of how we pitched it to health systems as we talk about it. And we let them, I think the important part is we let them bid on this. We explain through a series of webinars, here's the problem we're trying to solve. You might not like that we're asking you to compete with each other on price, but capitalism is a great thing. The market is a great thing. Let's play to those strengths. And so they are aware of it. They get it. I would be astonished if they referred out of their own system. It would truly blow me away. But I think over time, people are going to start asking the question, do I want to pay, I'm going to use pretend numbers here, $10,000 for this heart procedure here based on where I am in my deductible and co-insurance? Or do I want to go to this place where it's free? I can always go back to my doctor here after my procedure. But is the comfort and kind of where I am worth $10,000 to me? And if it is, that's okay. But that's why you have to pay more, right? Is because access is kind of a luxury in this situation. If I can get something for $20,000 cheaper, you might have to pay part of the difference. And so I think systems get it. I don't think they necessarily like it. I would say most, but for a couple, were very, very competitive in offering steeper discounts to get more of these bundled services. Something I was really excited about, and I think we'll have more detail on in a few months, is even smaller systems see this as an opportunity to drive more commercial volume and keep more care local. So it's giving them kind of an economy, like let's build an economy of scale narrowly, whether it be Eurogyne surgeries or other things too. Like they can build up centers of excellence. So it creates some opportunity to be like, just be the best at it, and then you will get more scope and scale, and then you get better at it, right? It's sort of a flywheel.
Yep. Brian?
the way I would think about it is there are sort of three modalities for employers to participate in the market. One is a passive purchaser, like I take any doctor, any hospital, and I sort of just, negotiate rates and it's last year plus X percentage. And that I think historically has been a large part of the sort of employer marketing, including state health plans. Then there's sort of the active purchaser, which is where we're going into, which is I want to get good value for our members, which is saying, there are a couple big health systems and they can compete, and I'm going to set up the terms by which they can compete and then make it so that the beneficiary benefits from that competition, right? So, Tom is, as he said, he's not taking a jet and going on vacation. And I'm an
Sure.
unpaid board member. I get a sandwich for lunch, which I enjoy immensely. So we're doing this for the state employees. And so those savings then can come back to, avoiding premium increases, improving benefit design, adding additional benefits. Tom mentioned population health. Uh, but the fundamental issue is if you need coronary artery bypass grafting surgery and it's $40,000 at one facility and $70,000 at the other facility, and there isn't a quality difference, we would be a poor purchaser if we did not strive to one, prefer that $40,000 procedure, make that $40,000 procedure cheaper overall for the state health plan, and then set up an incentive for the beneficiary to go to get the surgery at that facility, right? So it's not that um, anyone's trying to push around the hospitals. It's more so we want the hospitals to compete on price and quality, and they historically haven't had to do that. And because we're such a big commercial purchaser relative to, say, Medicare or Medicaid, as a comparison, if you look at in a hospital's book of business, commercial insurance often pays 2 to 3 times what Medicare does.
Right.
So we are responsible for a lot of their margin. And so where we move volume, they have to respond.
No, appreciate that from both of you. Maybe a couple of quick questions, Tom, for you from the audience about just kind of the mechanics here. So one is around kind of your comment about trying to keep the percentage of salary kind of constant over time. And so the question asks, this is assuming that future LSIs will kind of line up with the future increases in premiums. And is this a discussion that you all have had with the legislature? And is there a plan? What if LSIs don't come along and there's still a need for premium increases?
Yeah, so I mean, so it's a long-term goal, it's a long-term strategy, and I think, but we have communicated that to the legislature, and I would say, for better or worse, it puts a little bit of gun to my head and my staff's job too, right? Like if we're
Sure.
knowing we're not going to get more money to pay for healthcare, we have to figure out how to cut costs. We have to figure out how to better manage our budget. We have to figure out where we need to be more aggressive. We need to figure out what we need to do in a couple areas. So I do think it's also, there's a degree of holding me accountable for helping to manage costs and making sure that things we're doing are successful.
Yeah, I appreciate that kind of dual accountability. A question on the salary bands, and I guess the highest band is at 90,000, and so kind of a question of is that going to be reevaluated? How did you think about that? What about the example of the doctor earning the 250K, and so then those rates are the same. So maybe you could offer some thoughts on that.
Yeah, so I think it's a good question, and I can say I think my team did, and this is not an exaggeration, I think 77 iterations of what the different salary bands could be to get to a budget. And some of the principles we used is we wanted to get about 50% of folks in the first two bands and about 50% of people in the next two bands, and then try to make the bands relatively similar in size in terms of population. Because we were trying to achieve a couple things. One, on average, the 80-20 plan should cost a little over 2% of your salary for an individual. On average, the basic plan should be a little closer to 1%. of your salary. So with those principles, you only have so many mechanics and so many different ways you can do it if you're trying to hit to an average goal. And again, with over 550,000 people in that construct, it makes it a little bit challenging. We're also trying to do something else for folks in those first two bands. One step back, some feedback we've gotten from the first time I worked here beyond is it is not affordable to cover your kids on state health. And kids, generally speaking, are healthier than everyone else. It's good risk to get on the plan. Heard and agree. So what we did was part of how we had set up the bands is how can we also lower, not increase, lower premiums for people covering just their children in the 70/30 and 80/20 plan to make that a more compelling proposition to get folks on the plan. And also for families, the employee spouse tier and the family tier are now the same price. Because again, we got to make it more attractive to get folks with kids on the plan. We're generally speaking healthier. We can do more things here. So if we're taking all those principles in place, it kind of creates a nice box, and then you only have so many different ways you can kind of band and create machinations on. But the philosophy had evolved over time. So some of it was what got better or worse feedback from folks, but also like, here's 3 stated policy goals we want to do. What can we do given those things?
That makes sense. And is it something you plan on evaluating over time, or do you see that changing much?
So I think one thing we have looked at over time evaluating is removing the bands and making an explicit percentage of salary to a certain for individual coverage and then the kind of contribute. So it gets a little bit fairer in some respects. It also gets a lot more complicated in some respects.
Right.
So when we go into program in rates and contributions, it used to be we had 4. And now we have, 4 for the 80/20, 4 for the 70/30. Now we have 16 and 16. And the more complicated you make it, the more technologies, and this is not the most complicated technology I'm planning to be perfectly honest with you, but it does create some steps and it does create some variance and unpredictability in who's going to enroll. So I think the treasurer's ultimate vision is a flat percentage of salary for folks. Agnostic of bands, but given the time frames we were trying to achieve, this is kind of step 1.
Okay.
Yeah, and I think the treasurer's vision of having sort of a ideal target of a flat percentage for salary is a sensible one, and 100% echo with Tom that the salary bands, the staff spent a lot of time sort of ideating through those. Could they always be improved? Of course, but then there's also the complexity of administering them, and the same thing applies to pharmacy benefit manager or PBM formularies. Like, do you have a 3 versus a 5 versus a 7-tier formulary?
Right.
Sure, someone could do a 7-tier formulary, but it would be pretty hard for any consumer to figure that out. And 5-tier formularies are already a struggle for clinicians and patients. So I think at least for an initial implementation of salary bands, this is a good start, and that feedback is helpful.
Thanks, both of you. One comment, just hoping for research to be done on topics like our lantern discussion, to find out, does it actually save North Carolina money, and to see that play out, be that perhaps with university partners across the state, but certainly can be done with others too. I think it ties to your accountability point, Tom.
We are going to measure the heck out of this, right? I think the other, not just measure it because did it work or not, is because to your point, we have to course correct, right? We're going to have a new TPA contract in a few years. What functionality do we need to bring in house? Where do we need to amplify? Where do we need to dial down? So I think there's the research point of view of did this work, did this not, was it good, was it bad? But it's also, this is just step 1, right? Like kind of like I said, let's pretend there's no increase to salaries. Let's pretend there's no increases to some of the, I still have to manage the cost. So I need to figure out what actually worked, in my checking account, not it's not a theoretical exercise. I literally have X amount of dollars and I got to make them work. So we are going to measure the heck out of it. And that's why we are a pain in the butt to contract with, because of the audit rights we give ourselves, the ability to control some of those things. I assure you, we missed some stuff first time through, but we're going to continue to evolve and kind of grow this program.
Yeah, and I was gonna say assessing performance is something that doesn't just hold the staff accountable, it also hold us on the board accountable because ultimately the staff and the board, and the treasurer, we all work for the people. And so how do we deliver better value for the people in health purchasing? We have to make sure that what we're doing actually works.
Yeah, certainly. It's a member of the state health plan. I appreciate that mentality. I want to ask, maybe building on this point around the negotiation with providers, and at least some of what you're saying could be construed as kind of a more aggressive posture. I appreciate your tying to the market and to competition. And so, could you reflect a little bit about kind of the relationships, the sustainability, as you're working through that process? And admittedly, whether it's the third party administrator doing it or the state health plan obviously depends, I'm sure.
I think that's a fair question. And something I think about a lot coming from the provider side is there's a lot of challenges and a lot of people hitting health systems in different ways. And we are a piece of we are my entire world, but we are only a piece of an infrastructure. So I think the sustainability is going to come from the healthcare system. It's sort of boring to say the healthcare system is broken because it's like, duh, we all sort of get that. But I think of this as the path forward where you're going to have to ramp up where you're investing in some services. You're going to have to ramp down where you're investing in some services. And that's why we have to be sort of measured in our approach. But for this to be sustainable, we do have to shift certain things in certain directions. And this would not be a popular argument, what I would need to make. I don't think every health system at every hospital needs to do every service. I think there are core services like primary care, behavioral health, OBGYN, trauma, or emergency care that need to be done everywhere, need to be really, really accessible. But there's not enough doctors, like full stop. There are not enough nurses, full stop, to do everything well everywhere. And we have to help consolidate that in ways so that our patients are getting the best care, not just the closest care. And we have to make sure it's the most affordable, best care. And that is sometimes antithetical to the one closest to your house. So we're all gonna have to adjust on this together.
So kind of a great follow-up to that, from the audience, that kind of the question asking, are you investing in tools or mechanisms to try to help enable some of this consumerism? This individual is pointing out kind of some of the onus is getting put on the member to determine that location, given the benefits that accrues to them, and it's a significant time investment. So kind of how are you going to help support members in that exploration?
So
Yeah.
I
So I think
have a
go ahead.
quick thought before Tom gets into the operational component of that. I would say that was one of those questions that the treasurer and the board said collectively, if we're going to do this, we need to make it easy for the member. It can't be hard because it's already hard enough being sick. And so I think that Tom and the team have done a really good job thinking through the operations of how to make this seamless for the actual member.
Yeah, and so I think that's the point. Is we have to make it seamless. And so one thing we learned, so the previous administration had something called the Clear Present, which basically said if you're going to publish your rates, we'll pay you 160% of Medicare, and we'll do a copay reduction for members. Kind of no incentive on quality or access or other things. But 40% kind of specialty contingent, between 30 and 40% of members switched what doctors they saw to save somewhere between $10 and $65. So again, with lower incomes, medium salary, and around 60s, people are very price sensitive. So I think that's the most effective mechanism. And again, take some coaching and some understanding and trust building that cheaper is better under this model. So I think that is the easiest thing to communicate. Is like, you should go where it costs less. Again, cultural challenges. We are providing for Lantern, the surgical program, a card for members. Like, whenever you think you need an elective procedure, call this number and they will do the scheduling. They will do a warm transfer to get you that care for free. They will help you coordinate travel if that is needed. So we're trying to take the abrasion out. And I think the easiest way we're going to be most successful with this over time is weirdly by not communicating, by getting the copay and the cost incentives aligned in such a way that people are already at the providers that are providing those lower cost services, so it becomes second nature to them. So when you culturally know orthopedics, oh, I go to the lower cost setting for my first visit, and then when I get to the surgery, it's free. I think there's some cultural work that needs to be done. Obviously, we'll all communicate, but we have to build in the infrastructure and the culture to know that free is better, and free is going to help you get healthier. So that's the long-term vision, but in the short term, it is calls, different outreach, cards, membership cards, banging the door on price really, really loud, promoting what we're doing. Because candidly, members looking at prices on transparency tools and cost tools, like a good one is getting 12% of members, and I still got the other 88 to figure something out for. So we're gonna have to make it transparent. We're gonna have to have the provider refer to you that place. We're gonna have to make it free. We're gonna have to do all of these things. So it's got to be multimodal, and we, investing in a couple of those modes are going to hit the member on the head, but so then it's a place they need to go.
No, that's helpful and a constant challenge as we think about change in this space. I'll look forward to receiving my lantern card when it comes my way. Let's talk a little bit about coverage and changes there. So one is certainly kind of thinking about GLP-1s, and so I don't know if you have any reflections there, but beyond even the GLP-1 restriction, are there other drugs or services that are under review to try to think about kind of what is the value in return for the expense and how you manage that overall spend to keep the state health plan member and affiliates healthy?
Yes. So I would say we have a P&T committee that reviews the medication that is on the formulary. And they've started to really get into the conversation around the value. Like, how much value does this provide the members? Not just is it cheaper, but how much better does it make your health for the incremental price? I don't think y'all will be surprised to know a lot of drug manufacturers make drugs that are a little bit better, but a bit more expensive. And we need to start having the conversation of, similar to on the medical side, a broad formulary means we're going to pay the most for each of the drugs to have access to everything. We need to think about how we narrow the formulary over time in a value way that sort of minimizes disruption. Because the GLP-1 thing preceded me, but was extremely disruptive. I still get multiple emails about it every week. And I didn't work here when it started. So we recognize there's a sensitivity to those things. But I do think we need to have a real honest and most importantly, transparent conversation with our members about things are going to look different, but we're trying to do it in a value-driven way. I'll give an example about the GLP-1s that I don't think it's promoted enough. About 40%, 30 to 40% of GLP-1s for anti-obesity medications for state health plan members came from med spas, and about half of those were things that had been started in the past 6 to 12 months. So it was literally becoming just mills of like prescribing medications for what people said. This is quotes I've heard: "You're messing with my bikini season." That's not really the goal of the state health plan, to spend several $100 million on that. And again, GLP-1s are great; they work really well for a lot of people. But we need to have that conversation of like, is this worth the cost increase to everyone? And could we offer more benefit that is more beneficial for less money so everyone pays less? And what is the ROI on those things? And we will get GLP-1s back for some members with some utilization management, because I think it's the right thing to do. And I do think it gets a lot of people healthier. But we got to be intentional with that approach. And I think that is what we're looking into, is how do you build a formulary around improving health and measurable ROI return, not just in health, but in finance as well.
So I would add, I'm a big proponent of pharmaceutical product innovation that can change the lives of patients who are our members. And I was also joined the board after the GLP-1s were removed. And so then with an indication for obesity. And so this gets to the broader question of what is the plan strategy for purchasing high cost drugs, right? Because there's a strategy of, meat and potatoes, diabetes, high blood pressure drugs. But what do you do when the drug is $50,000 a year for 10 years, right? That's different than someone's, blood pressure meds, which are $50 a month. What do you do if someone has a 1 or 2 time administration of a $2 million drug, right? That's a lot of gene therapies. Personally, as a clinician, as a board member, I want members to have access to those. It's also unrealistic for the plan to just write a check without thinking about, is there a different way that we can contract for that? Can that $2 million drug be done as for 500,000 patients to the $500,000 payments to the pharmaceutical company tied to some clinical outcome for the patient? So we make sure they're getting value and they have durability of response. For some drugs, can we contract on total cost of care? So I think that, while the pharmaceutical product innovation is great for patients, we have to make the payments sustainable for the plan and for the members. And so that's going to require some value-based contracting not just as a buzzword, but as a very specific operational question for Tom and the team. And our P&T committee is very good and very nerdy, so I'm very grateful for them. And I know that in addition to in a couple of years rebidding the TPA contract, the PBM contract will also go out for bid. And so all of these will present opportunities for us to think more carefully about who the vendors are and will they allow us the appropriate customization to save money and expand access to drugs and services, and also do so in a way that's not confusing to members. Because again, getting back to it, I'm a health policy expert, but not all members are health policy experts. And I can tell you health insurance is so confusing that I get calls from around the country from other health policy experts trying to pick their insurance, right? So we should make things at the end of the day, yes, we need to cover more drugs in some areas, probably less drugs in other areas, and then think innovatively about contracting, and then finally make it easy for members. So I just effectively turned the rest of Tom's hair white.
I appreciate that. And again, TPM third-party administrator, Aetna at the moment, Blue Cross Blue Shield of North Carolina previously, and certainly something that we'll see who it is next. And then your PBM point, pharmacy benefits managers. So helping think about kind of what does the drug formulary, the drugs that are covered at what price, and as you're highlighting kind of value opportunities there. I mean, I guess just one follow-up question, Tom. Actually, first an observation. One of the great things, as you mentioned earlier, and I'll just highlight again, is you do have a population that you will serve for 20 years, for 30 years into retirement. So there is that opportunity to invest in health and support folks in the journey. And then the question, how do you think about transparency around this? That obviously in many ways, people often don't care about things until their individual coverage episode comes up, and then we care very deeply. But we need to be a part of discussions, often ideally beforehand, so we could try to think about how to handle it. And so how do you look at that part of this?
I think transparency is an important step. I don't think it is an outcome unto itself. And so what we're trying to do with transparency is put it in the context of the value, right? So is it more expensive because it is better and will make you live longer and it is accessible and you can do it? I think that's one thing. Where I worry about transparency is people see a sticker and then make a decision. I don't necessarily want someone going to someone for a very complicated heart procedure that's 20% cheaper than the best place, because there's likely afterwards to go worse. So I think how we are trying to think about transparency is along the lines of making it affordable for the things that are high quality, low cost, and easy to access. Because if it just becomes a pure price exercise, like I've done this for a while and I'm not sure I'm savvy enough to do it by myself to need to do those details. Like I could do it. I could call Brian. I could call heads of hospitals, but that's asking too much of everyone. So what needs to be, in my mind, most transparent is it cheap and better, or is it cheap and the same? And I think that brings nuance to the conversation. It makes it a little harder to navigate. I do think there's no reason rates should be secret. I think it's extremely stupid. But I do think there's a more nuanced way we have to think about price transparency and what's the problem we're trying to solve and what's the behavior we're going to try to get to. And I'm more focused on changing behaviors. And I think price is a tool. I don't think it's a solution unto itself.
That's great. So 2 more questions, and we have 4 minutes left. So I'll ask this one, and then I'll ask a final wrap-up question for kind of a key takeaway for you to leave folks with. So the question about population health initiatives, and basically tying back to your early comment, Tom, that had not been a priority for the state health plan in the prior administration. And so, can you briefly talk about how you're thinking about sort of carrots and sticks outside of changing, whether it's the clinic care arrangements, the pharmaceutical coverages, the smoking attestation has been removed, but there's really kind of a lack of, the question is saying there's a lack of incentives to improve their own health. So how are you going to try to encourage that?
Yeah, and that's a tough one, right? Because if you don't want to improve your own health and without an incentive, like I don't know how much incentive I can get. But I think what we're doing is we're trying to start where there is the most prevalence among chronic disease and there's the least accessible care. So around rural health, we've partnered with a company called Hello Heart that will help with hypertension, blood pressure screenings, particularly focusing on pregnant women. North Carolina's infant mortality rate is abysmal. So trying to focus on bringing care solutions into people's homes. So we're partnering with Hello Heart, Hinge Health to focus on surgical avoidance, particularly in communities where there isn't physical therapy. And then we're focusing on discharge care, at-home discharge care. So more focus at the current on rural, with other things like diabetes prevention programs. How do you keep people in their community? Because that's where I believe they're going to do stuff versus having to travel really far. Ideally, what can they do in their home to make it accessible to help improve their health? That between the doctor's visits, where we can get some generative data to send to doctors. Like if I do my blood pressure every day and it's fine, good. Like we should be monitoring that. But if it's terrible, like I need to have a doctor on the other end of that thing to how do you get me into care? So I think it's building connectivity between the home and the provider. So folks can spend less time with the doctor and more time with their house.
That's great. Thank you. So last question as we wrap up, kind of if you could leave state employees, North Carolinians with one message about the plan's future, what would it be? And so Brian, maybe I'll start with you.
I think that the plan is now on a better financial footing, and I think it's on a fairer footing for the plan members also in terms of premiums and what that looks like going forwards, because there's going to be more predictability as opposed to, is this year there going to be an increase? Is it going to be a big increase? Is it going to be a small increase? With a sort of target percentage, it's much clearer for the members. I think that the other thing is that some services could actually become cheaper through the implementation of a preferred provider network. And I think that the other thing that's really important is the onus is on us to make this seamless. The onus is on the members to use the preferred network, and we set up the incentives. But we want to make it easy for members to do that. And if there are problems, also we want to hear. Like, I've gotten emails from members about a variety of issues. And so I think we're always open to feedback and trying to do a better job, because I said, at the end of the day, we're here to manage your health benefits and make sure that they work for you. And if they don't work for you, we need to know why, because sometimes individual problems can lead to bigger systemic changes.
Great. Thanks, Brian. Tom?
I think Brian said it really, really well. If I boil it down to, this has to feel like a benefit to members. It's a help. It has to feel beneficial. And that's where we're constantly going to try to evolve it. So please let us know where it is working and where it isn't. But it's going to be different. And if you want to go see everyone for everything, whenever you want, it's going to look different. So how do we work together to make this a sustainable benefit that people value? Because otherwise we're sort of losing.
Great. Well, let me thank you both. I appreciate this kind of engagement, this level of transparency, and thanks for doing what you're doing for the state of North Carolina and for members of the state health plan.
Thanks so much.
Thanks, y'all.
Thank you.